welcome. My name is Mitch Guthrie, and this is the Long Letter Podcast. This episode is part 2 of my interview with Cole Meckle, pastor of Gathered Church, and we're discussing the services that Gathered Church provides. So there's a lot in here. I hope you enjoy listening, and yeah, let's get to it. So we were just talking after the camera malfunction here. That we've got way more programs to get through, so we'll try to pick up the pace a little bit so this doesn't go too long. But so what's next? So let's talk about another housing program, Zebra. We've only been operating Zebra for about a year, not quite a year. It's community behavioral health rental assistance, and Nate Judd is our program director for that. For Zebra, and it's been pretty amazing. This doesn't sound like huge numbers, but there's not a huge amount of resources to access. But also, it's not a small number. So 17 families, 17 households representing 27 people have been able to receive housing assistance through that program. And most of those are folks that were unstably housed or unhoused. And so that's a pretty big number, especially given there's just not unlimited resources. There would be, if there were more financial resources to utilize, there would be way more people. That it's
we would
limited
be able to use.
by resources, not by need.
Yep.
Demand is way greater than supply for this stuff.
Yeah, exactly. It is working then in that housing program. You are qualified to receive that assistance and that support if you have behavioral health diagnosis. And so in part, it's there to help individuals who are in need of treatment and care and to access that care and not have to concern themselves with losing their housing, or they need the housing in order to address their behavioral health needs or whatever, right? So
lining things up.
Yep. It's
and
great.
That wasn't a full year. That was split?
Yes, that's correct. That was 17 it will be coming up to a year. Actually, this month, it'll be a year. So that data only goes through, I think, middle of December.
Yeah, okay.
Yeah. So in addition to that, we one of the things, speaking of the hate mail, not really. I mean,
no,
I know you know, but I'm saying for those listening, no one will really get that much hate mail. It's mostly people showing up hating on me. But so we operate a syringe exchange, right? And so our SSP, we served 3,555 people in 2022 at the syringe exchange.
What was the number again?
3,555 people.
Wow.
Yeah. It's and it represents not just syringe exchange. So that number is specific to people that receive syringes, except we also offer a tremendous amount of other support services. So there's a lot to talk about, and we could do just a podcast on syringe exchange, and we should probably do that sometime, and harm reduction. But the way we operate the syringe exchange is certainly for the sake of public health as a whole, certainly for the sake of the health of drug users. But it also, so there's a ton of work that, again, we could talk about that's just related to public health and on multiple levels, as well as drug user health. But our goal and our desire, and my desire, is to see people find recovery, see people find hope, see people find life. One of my colleagues says, help people discover a life worth living, Yeah.
So, and I think people misunderstand. We do need to do probably an episode on that. There's the harm reduction part of it, which is getting out there, making sure, it incentivizes people to return needles, not leave them turn about. It helps the health of that community who are also a part of our community.
Yeah.
All that stuff is really important. I think some people have the idea that, Gather's driving up there, chucking needles out,
right.
Thing and all this other stuff. But that is just one part of the multifaceted approach, because you also have nurses that go and care for them. You have workers there that can help continually working the issue of housing, continually working the issue of mental health assessment, and so on. So like it's not just this one thing. It's like 10 things all in one vehicle. It's a clown car. Everybody gets out. And
right. Yeah. No, it totally is. It's like a big, it's like a team of people that go out every week. Care navigators, care coordinators, community counselor, nurse.
For all this stuff.
Yeah. Every week that's this team of people that goes out.
And how many people would be out there weekly providing these services if it wasn't for the SSP program?
Yeah, no, absolutely. That's the thing. And this is another way to come at it. Like syringe exchanging is the thing. Oftentimes it brings people there. And then they connect with all of these other services while they're there. Mm-hmm. And then they can start to work on like root causes, right? We're trying to minimize the negative effect on health community-wide as well as individually, and then work on getting closer to the root of why people are using substances.
Right.
And
because the substance use is a symptom, not a cause, typically.
Yeah.
It's usually a response to something else.
Yeah. I mean, I say most of the time that, substance use, addiction is it's a shame disease. That's people are either the thing that emotionally got them using was the feelings of shame and wanting to escape those,
which becomes a feedback cycle for them. It gets more difficult.
Exactly. So they want to escape those feelings of shame that maybe came by the way of adverse childhood experiences, or the shame that they experienced while using. And oftentimes the shame they continue to experience, right? That just builds and builds and builds. And so we're there to try and help overcome that. Like we're not showing up.
Break the cycles of shame.
It's like, we're going to show up there and we're going to look at you. We're going to see you. You're a human being. You're made in my perspective and our perspective and Christian worldview is in the image of God. And there's a sacred human being here before you that's immensely struggling with a multitude of things and feel like horrible. Right? Like they're not showing up with this like arrogant, proud sort of like, give me my stuff. It's like, no, they show up and they feel bad about themselves, and we're trying to meet them and help them not, because that's like the bedrock of transformation is experiencing somebody like showing you unconditional love. And we talk a lot about that. We also talk a lot about just unconditional positive regard. Like this sense of knowing that the person you're standing before is not defined by whatever you're seeing in the moment, as far as what their maybe brokenness is manifesting. But there's this one before you that you should be having unconditional positive regard for. You have a high view of this person, despite what appearances might try and dictate otherwise,
or even sometimes how they act. I mean, that's another thing that's been recurring in these relationships. Is these relationships start out difficult. They're hard to maintain. The person can be socially awkward or aggressive or whatever. But you talk to somebody who's reached the other side of recovery, and it's like they're so thankful people didn't give up on them at that time in their life when they were the worst and they were terrible to others or whatever. So it's a challenge to love people like that. And I would hope that everybody would agree. Like nobody's pro homeless, nobody's pro encampments or the conditions that these people are living in.
Right.
It's not that at all. And I think people think, I don't know. People talk about it like they're cats, if you feed them, you're just going to get more of them. And it's like, they're not cats, they're people, for crying out loud.
Right. Well, and like
I like how we're not going to talk about this, but we're.
There's just the tip of the iceberg, right? Right. So like, as offensive as people's thoughts are like that, like, hey, you feed them, they're like cats, right? It's like that's the exact opposite to reality. If we're actually going to really address the struggles that we have in this community, in whatever community that is, in all of our communities, and for that matter, in our own households, like we're going to have to engage individuals. We're going to have to engage the problems. We're going to have to engage the people struggling with the problems. And so if that means feeding people so that you can bring them together in order to address the struggles that they're having, well, I'm kind of suggesting that is what we have to do, right? And then we take those next steps. It's like you have to have a mechanism for connecting with people and relating to people and getting to know one another, right? Like, so yeah, in some part, I guess, you feed them and they will come. Yeah.
Right.
The hungry will come. The lost and the hurting and the wounded. You show up with nurses, and you know what? People with wounds show up. You come out with a community counselor and people that long for somebody to connect with them and see them and hear their stories. Guess what? They show up. And this is the way we actually become healthy.
Right. Well, it's like being pissed at a hospital because everybody in there is sick or has some medical problem.
Right. It's like, what do you think is going to happen here, right?
Right. And I think the hospital image is a good one in the sense that, that's a way of viewing this work is one of restoration and one of, It
is a really good image for it, really. It really is. Yeah, it's like, and the way and I get it, and I'm really sympathetic, and I really like to talk with people that don't see things the way I do, and I'm not even going to try and suggest that I feel like everybody should think about things the way I do or that we do or whatever, but I do enjoy conversation, and hard conversation oftentimes I enjoy as long as it can be somewhat peaceable, but just somewhat, not even, it doesn't even need to be entirely peaceable, just somewhat. But it's like sometimes people have the persuasion that services are they cause the problem, right. As if like hospitals are what make the people
being sick,
needing a hospital, right? Yeah. It's like, and I get it because like if you hang out at a hospital, it seems like there must be some association with hospital and sick people, but you're just wrong to assume that the hospital is making the sick people. Yeah. I'm not suggesting a hospital has never made a person sick.
Right. Well, that's where the analogy can break down if you look too closely.
Right. If you're going to push it that way, but right. I mean, that's silly at the same time.
I do think that there is something to be said to that issue where these things exist already in society. These people are here. Yeah. The people that are struggling with this stuff already exist, right?
Yep.
Now, just the fact that there are services that bring them in closer proximity, both to others and themselves or whatever, that's going to be visible. And there's no other way to do it. We don't like I said, you don't look at a hospital and go, man, that whole place is just attracting all sorts of sick people and whatever.
Right.
That's because that's the need that's being met.
That's an easy being met. Yeah. And this stuff gets complicated, and I know it, right? Like, where do you do this kind of work, right? Like, what is the right place to do it? There's no place that's going to make people happy. I mean, there's going to be there's nowhere that's going to make everybody happy. There's always going to be somebody saying like, don't do that here. Don't do that in my neighborhood. Don't do that in my cousin's neighborhood. Don't do that in this county. Don't do that in this state.
Not in my backyard.
That kind of basic attitude. And so like, that's one of the things the person has to just get used to, knowing that there's going to be some people that are going to be unhappy. And you can't let that like stop.
But you can't plausibly expect to reintegrate somebody into society if they're only allowed on the outskirts of society.
Yeah, exactly. Yeah.
I mean, we're...
yeah, I know. Here we are trying to go...
Other.
Yeah, I know, right? Well, I'm hoping somebody else pays attention, so... But so let's just run down some more stats here. 100 every week. So these are weekly stats. 120 lunches we give out every week too on the SSP. We also give out socks and hats and gloves and hygiene items, and we are able oftentimes to give away tents and tarps and blankets. We already mentioned this stuff, but we connect a lot of people with different resources and send referrals and transport people all over the place. Bring people to the hospital. Speaking of hospitals, that's an unfortunately common activity for our outreach team at the SSP. We will encounter folks that the nurse sees, and their level of need far exceeds what could be done in the field, And so we bring people to the hospital. Like one of the goals is we intervene before somebody needs hospitalization, because as far as a fiscal standpoint, it saves our community tons of money to care for somebody's wounds before they get to the point they're septic, but not all and need hospitalization or even bordering on that. But there are times when, somebody doesn't come out and tell us about it. There was an individual not long ago that had a bite, and the bite got infected. They were embarrassed about the location of it, and so they didn't tell anybody about it. It got really bad. By the time one of our nurses was able to look at it, he probably would have only lived another 12 hours and barely made it at that. Was transported to Seattle, St. Pete's and Olympia. Mm-hmm. And he was in the hospital for weeks and just barely survived from this infected wound.
Of that is way higher than, say, the cost of preventative care.
Oh my goodness, yeah. I mean, hundreds of thousands of dollars for his care. And if it's one of those situations, if we could have intervened with that earlier, it would have been, a little bit of ointment, maybe something to drain a wound.
You can't intervene if you're not out there doing it every week.
Right.
Is basically the point.
Yeah. And this kind of stuff happens regularly. It's not... living outdoors obviously creates an increased potential for risk and hurting yourself. And there's also a lot of stigma attached to this, right? So this is just what it is, and I'll just say it bluntly, but a lot of times folks that are living outside, that they're showing up looking for some medical care, are not getting very good care for numerous reasons, and I'm not going to suggest that that's not complicated. Some of it has to do with the behaviors and the attitudes of people that are showing up looking for care, right? Yeah. But they sometimes have a hard time accessing the care that they need, and they just won't go looking for it. But this is why we show up and try and intervene.
Right. I think there's this mindset that people have about how Gather approaches things. Yeah. And I'm going to use an example from the movie Elf, where he's walking to New York, and he sees a raccoon and he wants to hug the raccoon, and the raccoon wants to kill him, and he ends up getting attacked by the raccoon. I think people think that Gather, or people that work for Gather or volunteer at Gather, have that sort of just doe-eyed approach to things,
right?
That would just know, oh, you guys just think this is all whatever. The truth is, there's a lot of discernment that goes into this. A lot of, these are tricky things and people and situations to work through.
Yeah.
At the end of the day, so they're not going out and trying to get a hug from a raccoon. You have to kind of work on the level with the raccoon, and you have to, there has to be. Yeah. Not everything is like that. I don't mean to make it sound like that's that sort of aggressiveness in the situations, but there is a certain, there's just a ton of discernment required to do this.
Yeah. Yeah. One of the nurses that goes out on the SSP normally she's been at this kind of work for many, many, many years, back to the rise of the AIDS epidemic, and she was going out and working, offering care to folks when all they could do is put out a bucket of bleach water and help folks bleach syringes and offer other levels of assistance and care to folks, right? And so there's I don't know, I should add it up one of these days, just of all of our medical staff, there's hundreds, if not thousands of years of experience. I don't know about thousands, but hundreds of years of experience at this kind of work, right? And yeah. Okay.
Mitch is pulling out all of the animal analogies. We've done cats and now we've done raccoons. And we need to do 2 parts right now.
What's funny, the recurring theme there is how people reach for these analogies.
Oh, I know.
I like it.
Depends on the perspective you're going from.
I don't think it's worth it to cut any of the information out.
And that's the risk of the analogy there, is because I am not saying that people who are in need of these services are rabid raccoons.
Right.
What I'm saying is that we are not Elf, right?
Right. Yes.
Just like they're
Don't
not
associate
just like
with the
they're
wrong
cats,
part of the story.
So, next program on the list.
So on my list next is our Meds First program, also known as the Health Support Teams. It started off as Meds First, and technically it's Health Support Teams, but we've never lost the moniker of Meds First. So Meds First Health Support Teams is a low-barrier medication-assisted treatment program, working with those primarily with opiate dependency. So diagnosed with substance use disorder, folks that are struggling with opiate use, and not limited to that as we've expanded in health support teams. But the medication-assisted treatment portion of it is targeted specifically at folks struggling with opiate dependency. And so we operate our program as it's a low barrier program. And that doesn't mean what some people think. Some people think that means something other than what it does. Low barrier simply means that if you decide today that you would like to address your opiate dependency, you can show up and you're going to see somebody almost every night of the week, 5 nights, Monday through Friday. You're going to see not just a doctor, not just a nurse, not just a care navigator, but you're going to see all 3 of those people in the same visit, and you don't need an appointment to get there. It also means that if you schedule your follow-up visit, let's say you show up, you see a care navigator, you see a provider, you see a nurse, you're determined to be a good fit for medication-assisted treatment, and you are started on Suboxone that you or another buprenorphine medication, and you are scheduled for a follow-up visit, say after all of that, you don't show up to your follow-up visit for whatever reason, you're not going to be shamed or ridiculed, kicked out of a program. We will work with people at the pace that they're ready to be worked with, if you will, and a lot of support, a lot of encouragement. One of the things that there's a lot of that is not always understood is there's a lot of accountability. It's different, right? Like the accountability looks a lot like the accountability we were talking about earlier, where you're meeting people where they are and you know that there's a lot of layers of struggle that you're going to have to work with people through. And so, but again, you're working with folks, doctors, providers, care navigators. Care navigators, most all of them have lived experience, folks that have struggled with substance use themselves. So they understand what it's like to be across the table, if you will, or across the room, or the other person in the room that's struggling to overcome their substance use. And so on many ways, like they have insight that other people aren't going to have. They also have, they're like an example of somebody that's doing it across the room from you, or across the table from you, or across the somebody that's looking you in the eye, right? And so tremendous amount of support and encouragement that comes by way of having that peer, that care navigator. They call you, they follow up, they engage and communicate with you, they cheer you, they give you a hard time if you need that. Most people don't, but right. It's a beautiful model. People always walk away with Narcan. We had almost every one of our programs, you can get your hands on Narcan. For those of you who don't know what Narcan is, it's a opiate overdose medication that reverses an opiate overdose, stops it, if you will. And we could go into the science of all that, but for another time.
Well, I do think, like, for people who don't know, somebody that's overdosing on opiates, the receptors in their is it their lungs? Or
it's in your central nervous system.
Central nervous system. Basically, the thing that tells you to breathe. Basically, it stops those.
Yeah.
And a person will asphyxiate usually, and then have a cardiac event typically, and that's what kills somebody from. If I'm
I mean, there's a lot of things going on, and I'm not a doctor. I just am around this stuff all the time, right? So there's a lot of things going on with what's happening within those receptors in one's central nervous system. But one of those things is that, yes, it affects slowing of one's breathing, and that is what then an overdose on opiates, what kills you is.
So Narcan can be given to somebody. It directly affects that aspect.
It blocks those opiate receptors and doesn't allow the opiate to.
And then and side effects are
of an overdose.
No, side effects of Narcan.
Oh, none.
Yeah. So like relatively safe to have.
Yeah, it's super safe. Like it's totally does nothing to somebody. Like if
you don't have that issue with your receptors, it's not going to.
If you have an opiate in your system, that has nothing to block, right? And so it's not going to have any negative consequence for somebody that or to administer it to someone or to themselves or whatever.
Yeah, it's not like a drug that has a side effect that people can abuse or would abuse, or if somebody got to it and inadvertently somehow administered to themselves Narcan, they would be in medical.
No, they wouldn't have any.
risk.
Yeah, they'd have zero. It would bother them none. I mean, there's some different versions of Narcan. Naloxone is actually the drug, and so you can. The one that's known most to communities is the nasal delivery form, right? And so there's a little thing that one puts in their nostril or puts in the person's nostril and pushes a little button, and it creates a mist that goes into their nose. But there's intermuscular versions of this as well, right? And so there was a story I heard from a person that does training for how to use all the different forms of intermuscular or the nasal Narcan or whatever. And so she was telling me a story about accidentally injecting herself with like an EpiPen version of it with a live one, not and it's like she tells this story. It seems like, like that's not a great story to tell people. If I did that, I don't know if I want to go telling everybody that. But at the same time, it was like she was trying to demonstrate like this isn't going to hurt you. If you get this stuff in your system, it's not going to harm you. So that's a really important thing for people to know and understand. So
I don't see people arguing against having EpiPens around, and those are going to do a lot more to you than just Narcan.
And so naloxone totally a medication that
very specific use, very specific side effects outside of
Yeah, and so we distribute a lot of Narcan, a lot of naloxone in the community, and hundreds of kits every year. And we, it's interesting situation in trying to get it into the hands of people, and different people want it for different reasons. There are many different access points nowadays. Technically, if you have a opiate prescription, you are supposed to be offered Narcan wherever you pick up your prescription, at least knowing that it's available for you, so that if you accidentally take too much of your opiate or somebody gets into a prescription that shouldn't have and ODs, you have something you can do about it. And so, it's good information for people to have. If you go down to your local pharmacy and request it, there's standing orders, so prescriptions that are written they're called standing orders that allow pharmacies to distribute it without the specific prescription you come in with for it, because it is a prescribed drug, even though it doesn't,
it has to be under some sort of standing order for you to receive it.
Yep, exactly. So, so anyway, if you're listening to this and you want Narcan in your household, or in your vehicle or wherever, you can talk to us, but you can also go to your local pharmacy and talk to them about getting it.
And there's some basic training that comes with it, like how to use it. And
it's super not complicated, right? It's kind of like, we were joking about this earlier today, and it was like the training could honestly consist of like, if you think somebody is overdosed, go to their forehead, follow the bridge of their nose down to the nostril, insert the dispenser into the nostril and push the button and step back. And it's like, there's more, like, I don't mean to sound jokey about it because it's serious business, right? Big time. We'll get to that in a second, but it's just like, it's not complicated to administer.
Right.
The nasal Narcan is intended to be just like as simple as you can possibly get. And really the training is more about how do you recognize the signs of overdose?
Right.
Yeah, how to administer it. How much do you give? Do you keep if you have more dispensers, if the person isn't coming out of it, do you keep giving it to them? And the answer to that, by the way, is yes. And then from there, what do you do after the fact?
Like,
right?
you don't just give it, walk away. You call 911.
Yeah, you call 911. The inhibitor that blocks the uptake of opiates will only last for so long. And if somebody has enough of an opiate in their system, in more than theory, the naloxone could wear off before the opiate in the person's system wears off. Mm-hmm. And so people do need to seek medical attention. Now, not everybody will do that, right?
And so that's where, and this is a part of our Meds First clinic. Mm-hmm. And also you'll hear Suboxone clinic, right?
Yep.
That's kind of the same terminology. And one of the things, though, I do want to kind of go back to, because we only kind of briefly touched on it, was that idea of, now the word escapes me, it's not like you're just going out and helping people and then that's it, or that you're trying to, you're fine with people staying in addiction sort of thing.
Yeah.
The programs attached to it, around it, the training, all that other stuff. The idea isn't to, let's get into the topic of enabling, because people, I think there are some that would be like, well, if somebody's having, ODing on, opiate, whatever stuff, death is the consequence for that. And they struggle with the fact that Narcan exists, that it exists in easily usable forms, or even like things like accountability and, whatever for the stuff. So like, let's talk about that in terms of how the MedFirst Clinic operates, or any of these services.
Sure.
It's not an abandonment to a person's problems. All of these are structured in a way to bring people out of substance use disorder or whatever.
100%, right? Like it's all about journeying with people to health. This is why we operate the way we do. I mean, there's a lot of folks that can get access to the treatment services that they need. We try and make the on-road to recovery services as simple and straightforward as possible. Continue to offer those services if somebody's showing the slightest desire, and offer as many additional services to that individual as we can. So like, for example, when the Meds First, and by the way, just a statistic to throw out there, we had 302 new clients in Meds First in 2022. So that's, yeah. And we have about 120 active clients at any given time. So anyway, we could delve more deeply into those numbers and what that exactly means for another day.
Yeah. We got like 10 episodes.
I know, right. I mean, it would be fun to circle back and just spend a lot of time on every one of these programs. There's some more than others, but no, so like one of the things people don't recognize, and I get it, because if you haven't ever been there and done that or been around this stuff, you wouldn't recognize it. But if you are somebody that's in active addiction and you're trying to get into treatment services, there are not very many on-roads to those treatment services. I'm not here to criticize anybody. That's not my point. We do have some really broken systems, and I understand there's a lot of work that has to be done in transforming systems. But a lot of treatment service has been built on a model that's fiscally based. It's on a capitalist fiscal model, and I'm not here even to criticize that necessarily. It just is what it is. And so agencies that are going to provide something like medication-assisted treatment, they are only compensated for their work if a client shows up. And so there's no incentive to really work to try and address the needs of those who are least likely to show up for services. And guess what? Lo and behold, if it doesn't turn out that folks struggling with substance use are not always likely to show up. Right. And so, and the more deep in the throes of that you are, the more of a struggle you're going to have to show up to receive the services that even maybe you desperately want, that you need. I don't know many people in active addiction that aren't like, man, I really need some help. And so a low barrier model is working to peel away that capitalist model of fiscal. It's intended, I guess, to be a fiscal accountability, but that you can sustain a program without the certainty that the folks are going to show up. And then too, lo and behold, what do we find out? That, a whole bunch of people show up and a whole bunch of people find long-term recovery. And so again, it's like part and parcel to Gather's desire to like meet the needs of the underserved. There's a lot of people that want help. There's a lot of people that are going to really struggle when they first seek recovery services. There's a lot of folks that are going to get started, and it's going to be fits and starts for a while, and it's going to take them some time to get stable and get stabilized. And if the reality is they might be able to see a doctor and a nurse or somebody at a clinic one time, the likelihood of them showing up is going to be low, and the likelihood of them getting kicked out of that program then is going to be high. And I get it. That just is what it is. But what we're doing is trying to do something different than that. Trying to say, hey, you know what? You might fail miserably at this 4 or 5 times or more, Keep coming back. Keep trying. We're going to keep working with you. We're going to keep cheering you on. We're going to keep doing whatever we can to help you find recovery.
I think it's just a difference in incentives, right? So the fiscal incentive isn't as efficient as actually getting people out of addiction and the help they need because of the, go back over, start from zero again and whatever. Versus the incentive to actually get somebody out of addiction.
Yeah, right.
Like, so one incentivizes, a fiscal aspect. One incentivizes the actual outcome that you want to see. The outcome.
Exactly, right. And it's fascinating to just pry into just how broken so many of our services are, and the people are incentivizing the wrong thing, assuming that like folks don't really care to help people. I don't meet very many people that are giving of themselves in recovery circles and in treatment facilities that don't really want to see people grow and change. And so there's other ways of offering levels of accountability for agencies that are doing work. The fiscal one is actually proven to not be a very good way for accountability to do a good job. And outcomes are what need to be incentivized.
If it's toward an outcome, yeah.
Absolutely. And so, like, just from a fiscal standpoint, not to get into the specifics of numbers, but the number of people that we serve and the number of appointments that we have, if we were to actually bill for all those services like other clinics do, it would cost, we would bill for over twice the amount that we currently receive to run the program. Anyway.
Yeah, it just comes down to what you're incentivizing.
Exactly.
And outcomes-based incentives are obviously going to be more beneficial to the people that you're serving.
Yep. And that is the way a lot of healthcare stuff is moving. So fee-for-service is what has been the model of payment for a long time. That would be a person shows up, they have something going on, you treat that need, you get paid X amount of dollars for what you did. A lot of this model is moving to what's called value-based purchasing. And it is about saying, this is a good value for this amount of work. Hit these benchmarks, do this work, and you will be compensated in this way. And then on top of that, and that's usually a more meager amount of money, on top of that, we want to see these outcomes. And we want to see this number of people being treated in this capacity, or you're encountering this many people. And there's so many other things to say about this. The current models for recovery and treatment services don't really do much to fund any kind of outreach and engagement kind of work. So there's that relationship building component that's so important. So one of the things that we recognized that we needed more of in the Meds First program and this low barrier MAT program was that we needed counseling services. We needed more counseling services, and we needed more easily accessible, low barrier, relationally based counseling services. And so we added a full-time counselor who is referred to as our community-based counselor, and they go out in places like the SSP. They sit in on appointments in the Meds First clinic when clients come in, if they so would like the person to be there, if given they're available at that moment, which sometimes happens, sometimes not, but we try and make them available as much as possible. And they get to know the person's story, they build some rapport, because at the end of the day, substance use isn't just about a physiological addiction to something, right? Like there's a lot of complexity and stuff going on there, but substance use, as I said before, is like a shame thing. And if you're not going to go back and do some good counseling and therapy and work with people to deal with root causes, you're not addressing the whole person, and you're not addressing the thing that's compelled people to feel as though substance use is a good way to deal with life. And so again, in this low barrier MAT setting, here's this community-based counselor that's there to sit with you, to talk with you, to hopefully, again, build rapport enough to then nurture you and coax you into a situation where you can start to address some of those root causes. And that's so massively important. And we need more of that. We need a lot more of that.
Yeah. If you had a house and you're noticing a crack in the wall and you seal that up and whatever, and then later it comes back and it keeps coming back no matter what you have to do, you have to ask yourself, do I have a foundational issue here to address?
Yeah.
And that's more work. It's harder to quantify. It's there's a lot of complexity in there. And I think that some might look at Gather and be like, oh, we just love all these systems that exist. And what I've actually seen is the Gather is just always working creatively within the systems that exist. Like there needs to be a reform. There needs to be things rethought. Nobody's denying that. So the issue is like, work with what you got. So sometimes you have to be more creative. Sometimes you have to add a counselor to your team. Sometimes you have to do this, and this. And if the goal is, to make money, I don't think this is the field to be in necessarily, unless you don't. But if the goal is to actually genuinely care for and help people and kind of pull these lives out of the river sort of thing, it's a lot of work and it's a lot of creative thinking to get there.
Yeah, it certainly is. And, we've got some amazing partners in all of this that are doing a lot of hard work to try and determine what are the best ways to engage individuals and change the way the system supports these efforts, right? So going back for just a second to that community-based counselor role, and I know some of this vernacular isn't going to like jive with some folks, doesn't make sense, right? But this value-based purchasing model. So not fee for service, not just you're only able to sustain the scope of work because of a specific person that was met with and talked with and for 15 minutes and you can bill at this rate or something. What can't happen in that model is that initial relationship building piece. Like there's nothing in the system as it currently exists to compensate a counselor to go to something like an SSP and meet with people, to talk with them. Folks that desperately need that level of care and counseling, but would never show up at somebody's doorstep asking for it for a lot of reasons. Sometimes because they feel unworthy to ask for it.
Yeah.
But in changing that, so like generally speaking, then that just doesn't happen unless it's somebody just out of the goodness of their heart that has the skill to do such a thing showing up. And that's great when that happens, but we just can't rely on that all the time, right? There are not that many.
Not in a system that's built functionally, not relationally.
Right. And so then with the system, with part of what we're doing is like, we're finding creative ways to fund that kind of counseling work so that that person can go and a program can be fiscally sustainable when all that's happening initially is saying, hey, my name is Sally. I'm a community counselor. Would you like to talk? Or how you doing today? Or I like your coat, or whatever is the beginnings of a relationship that then can become a therapeutic relationship, right? So those are things that like we really need to seek transformation of. Like we need to embrace those kinds of things. And for just the like purely fiscally oriented person, lo and behold, these things also are fiscally responsible approaches. Right. It's way, and I'm fiscally conscious, but I'm not fiscally, like that's not my thing. I'm motivated by helping people and caring for people's needs and stuff. But it's nice when the two things like line up, where it is actually, it saves us money in a community. And it's the right thing to do for the person. I love it when those things line up. And so oftentimes they do. Abandoning people to their struggles is not good in any way, shape, or form.
And ultimately, it is more expensive.
Yeah.
At the end of the day, and that's...
Well, I mean, just think about the fact of like how many, you're going to offer people good, meaningful engagement and treatment services a handful of times, or are you going to offer them BS 1,000 times, right? It's like, it's just like anything else. You're going to put tires on your car that drive for 1,000 miles and go in and have them put on and over and over and over again, but they're only $100 a pair, or a quattro, a four. I'm an idiot. You got to edit that part out. No, not really. I'm actually a car guy too, but anyway, or you're going to buy a good set of tires, put on your car and drive it for a long time. Right. And you put out a little more effort to begin with.
Or just address the right problem.
Yeah.
That
was a terrible analogy I came up with.
That's okay. It's late, by the way. This is going long. Okay, so that's the Med First.
Med First. A lot more to say about that. This beautiful program. We absolutely love it. Got a team of nurses, team of doctors, team of care navigators, counselors. It's incredible. I've watched just lives just absolutely turn around. Another program, Recovery Navigator program. We've been operating that in Lewis County now it's going on a year. February technically was when that program was really launched. And there's a lot to say about it, but in a nutshell, there's a couple of different folks that are involved. Great Rivers BHASO is involved in that program, and they're in a couple of different capacities. They're the fiscal agent for that program, and they also have a director from that program that oversees a lot of the work. There's a program manager that is part of Cascade's team, and then we have 6 folks that are in that program, and we do all the boots on the ground work. And so what that looks like for us is we have 3 case managers, 3 outreach workers, and we receive referrals from the community. Could be law enforcement referral, could be self-referral, could be anywhere in between. And those referrals are for folks that are struggling with substance use or are believed to be struggling with substance use. And we go out with our outreach team and engage those individuals that have been referred to us, build a relationship with them, encourage them, help them from offering them some clean pair of socks, access to harm reduction supplies, to getting them connected with programs that would do assessments and bring them to detox. And so the Recovery Navigator program is birthed out of the recognition that just incarcerating people for possession of drugs is itself not an effective way to engage people and address what they really have going on. And so, it's just like anything else. If you, when you see no evidence of something working, you got to make some changes. Criminalized approaches to addressing behavioral change is proven ineffective. So there's a lot, again, to say about this, and as far as criminalization, decriminalization, legalization. But at the end of the day, I'll keep it really simple. Arresting people that are struggling with substance use is not very effective in addressing people's needs for recovery. Can it happen? Absolutely. Like, can somebody be arrested for their drug possession and find a program through being incarcerated that changes their lives? It can happen, right? However, what we see more of is people being arrested, released, traumatized through their arrest and their release, with more barriers on their record for getting housing or getting employment. And it's just, again, ineffective. We need other ways to engage individuals, meet them, and encourage them into recovery. This program is all about that.
And I don't know if everybody would recognize, but these programs are not mutually exclusive. There are things that work within the system, say like the drug court program.
100%.
That, I just talked to somebody that had gone through it and it changed their life. Mm-hmm. That can exist alongside of other methods of, addressing people that doesn't just have some revolving door of, get in, get your, whatever it is, deal with all the legal stuff, all that other stuff, and then end up having to go through that all over again.
Absolutely. These are not exclusive to one another. I mean, sometimes things like RNP and things like drug court are pinned against one another. I don't see them that way at all. There's some issues related there concerning what charges qualify you for drug court. And if those aren't charges any longer, then now what do you do in order to qualify people for drug court? However, that's just some problem to work out. These programs need to exist.
They're both efforts to address the issue at the end of the day.
Absolutely. We need to work together on things and not in opposition to one another. I mean, 3 of our staff are drug court graduates. So we love drug court. There's a lot of wonderful things that can happen in drug court. It's not the solution for everybody though. It's a solution for some, and if you will, solution. It's a great help to many.
Yeah.
But it's not for everybody. Right. Some people have other barriers, other issues. There's a lot of reasons. And two, what RNP is seeking to do as well is early intervention. We want to reach people before when they're, I don't know, early intervention.
Yeah. Well, you're going out to them, you're finding them, you're trying to get them the help then, and not after they've accrued, charges or whatever that is.
Yeah.
And it's just like any other thing in life. If you have that bite thing that person was dealing with, right? You deal with it earlier, the treatment and the cost and all that stuff and recovery is way, way faster than, letting it get, sepsis or whatever it is and end up in the hospital and, all that stuff, almost dying.
Right.
So and I think it's good to have things like drug court that can catch people in the system and give them options.
Yep.
And obviously we know a lot of people here that have been through the program successfully. That's great. These are not mutually exclusive. These things can exist at the same time. They can both be working toward the same goal, which is to either get somebody the help they need who's already landed in the system, or to prevent somebody from landing in the system so that they can get the help they need.
Yeah. Yeah. It really comes back to some simple things as far as relationship building, a lot of case management, RNP, as far as folks that have been fully enrolled into the program, they get really long-term case management, somebody that is able to be by their side, take them to appointments, connect with them, walk with them, help them find housing, help them find whatever resources they need in order to take next steps in their recovery. Right? Yeah. So it's a really great program. We've received 120 referrals just since July. So since starting in July 7th was when that program was really operational, and 120 different referrals. We have 67 active clients currently. These are all folks in Lewis County, and we do this Lewis County wide. It's there's been some amazing things that have happened already in just the early months.
I don't think people realize how local the problem is. There's this idea that people are bussed in or shipped in or whatever, but at the end of the day, we have people here that live here. They grew up here. They have family here. They have some sort of connection here that are in the middle of these issues that are thorny and complicated.
Right. Yeah, I know that's a topic of discussion, right? Just as far as the folks that are here, how many of them are from Lewis County?
Allyson, write that down. That's another topic.
Yeah, there you go. Thank you.
We're at 10 topics now.
Yeah. That would be just a fabulous one, though. I'll tell you how many people in Lewis County that are struggling are from Lewis County. And often, the discussion too would be like, what does it mean to be from Lewis County? But anyway.
Yeah. There's a legal definition.
Right. Right. And we'll save that for another day. So another one of our programs, there are two I'll mention kind of simultaneously. So care coordination or pathways, and also care connect. So care coordination has been a program we've had for, 3.5 years, 4 years, something like that. And it was a little different during the COVID lockdown and more social distancing time, made it really difficult to operate it. But it is it's a case management program, really. Pathways is a specific program that helps a person assess somebody that's showing up with a need. So let's say you show up and initially you're looking for help because you have dealing with food insecurity, let's say. And you would sit down with a Pathways care coordinator. They would assess you and they would help you address that food insecurity need that you had. But then they would also in that assessment, determine other things that you have that are needs you're not even maybe showing up for. Maybe it turns out you don't have a doctor, or maybe it turns out too that you're unhoused, or maybe Mitch, you're pregnant and so you don't have an OBGYN and you need some of these things or whatever, right? Or maybe you're a smoker and you want to stop smoking. And so the assessment tool helps determine some other needs somebody has that are part of the overall quality of life and whole person care, and would then at the appropriate time start to address some of those other needs that the assessment tools would generate. And then it also helps with the person that's the care coordinator themselves doing this level of case management. It prompts them and helps them, okay, what's the next step I would take with this individual in order to address this other need? Like, so for example, within the system, it would help connect you with let's say you needed an OBGYN, all the local OBGYNs, and then you could help make phone calls to connect the individual with medical care.
It's crazy to me. It's not crazy. It's just, I think it's telling that so many of these services or functions that Gather does is almost completely related to counseling or navigating people through existing systems.
Yep.
The barriers are so complicated and labyrinth-like, and you can meet this, but only if you do this, but not if you do this. Oh, and were you here on a Tuesday? Well, I'm sorry, that excludes you from this program.
Hey, if you're looking for a good time, go to another state and try and stay there and discard of your ID and try and get a new ID from Washington while you're in the other state. It's like...
Sounds like a lot of fun.
Impossible. Like, man, I'll tell you, like, I've got a master's degree, and it is next to impossible to figure out how to navigate a system when you're in a state and stuck in a state, and you're probably stuck in that state if you don't have an ID, and you're trying to get your ID from the other state when your ID's in the, Washington in our case, right?
Right.
It is insane.
And multiply that by every need you can have.
Oh yeah. Right? It's like, and it's not because people are trying to build crap systems. It's just that things get antiquated and they get difficult. ID is one of those. Seriously, like that is such a hard thing, and it never feels like it's the same. Say somebody's here from Montana, they lost their ID. You can't really do much. You can't hardly even get somebody a hotel room if you don't have
Montana?
an ID. Well, it's not the Montana piece.
We're going to need to, you have to go into this program for Montana lost IDs.
Everybody's thing is a little bit different, right? And so it's like you almost have a specialist for every state in the union just to know how to get somebody's ID back. And so like we have people, this is just something that happened last week or 2 weeks ago. Somebody has some checks that are in his name. They're for him. They are his disability checks, and he has lost his ID, and he doesn't have a bank, and he doesn't have a bank account, of course, and he also doesn't have an ID. So he has money, and he needs the money, but he doesn't have his ID, so he can't cash the checks. And he's floating around with these checks, and he doesn't know what to do. And like it's anyway. So step one is getting the ID, but that's just not an easy feat. So yeah, systems navigation, care coordination, journeying with people, walking with people. I mean, it's no wonder why folks give up. I mean, on that note, as hard of a rap as people that are struggling in communities, say unhoused folks get, they are some of the most resourceful, resilient, and incredibly brilliant people I have ever met. I mean, really, it's just a matter of putting the pieces together and helping folks move in a positive direction. So you're 100% right.
You talk about this stuff, and I'm just hearing a lot of this work is just helping people navigate existing systems.
Yeah.
And all of the, smorgasbord of requirements and rules, and part of it is sad. Mm-hmm. Part of it is, I think, just it's how humans operate. Any system that needs to function can eventually develop a complexity where it's like, all right, we need to redo this. All these things exist for a reason at one point,
Yeah. Yeah. So. Well, and there's so many facets of some of this. So like, I think when I talk with folks and they discover that somebody can be released from jail without an ID. And then what do? Got no place to go. I mean, let's just say they don't, right? Many people released from jail have no place to go. And again, I'm not trying to pick on any one entity. I'm just talking about broken systems. So systems set up in such a way that if you're booked for a particular number of days and your booking time, say, is midnight, you're going to be released at midnight on your release date. And you could be released at midnight with no ID, with no resources, with no idea of where you go next. So even simply from the standpoint of a safe community, it doesn't create a safe community. It also doesn't do that individual a doggone bit of good. And it just is what it is. What I'm talking about here is that people are, and I would be too, but most people aren't aware of stuff like that. Yeah. And they're shocked to find out about it.
And in a very weird way, in these systems, it makes sense how it came about. Mm-hmm. But at the same time, there's a lot of these things that are overlooked. The complexities of just something as simple as being released from jail, right? When you did not get picked up at jail,
right?
They don't return you to your point of arrest or anything. Right. So thinking
well, and
through
some
that.
people will say something like, well, just don't get arrested in the first place. And I'm like, yeah, that sounds like a great idea until somebody's arrested, and here we are, right?
Yeah.
It's like, that doesn't do us any good.
Okay.
We still have to figure this out from here. Yeah.
Right.
Yeah, absolutely. So, but you're totally right. A lot of our work is about navigating people through really complicated systems. And it's not even just sometimes it is complicated. Sometimes some of the systems aren't complicated, but it's just really lonely to try and figure it out by yourself or to even know where you go.
Well, and so much of it depends on what's your phone number? Can I text you?
Right.
What's your address? One thing that Gather provides at the atrium is mailboxes for people that don't have an address.
Yeah.
So critical, especially with government entities that can't always just send, the process is complicated. So providing that for people it sounds so stupid, right?
Yeah.
Mailboxes.
It doesn't to me now, but it would have back in the day. Yeah.
But it's so critical to what's going on.
Oh, yeah. Well, we can circle back to just as this is relevant to getting an ID. Like some states won't send proof of identification like birth certificates and such to general delivery to a PO, to a post office in some town, in this case, in Australia, let's say. So if you are unhoused and you don't have an ID and you're from a state that won't send any information such as a birth certificate, a replacement to general delivery at the post office, then what do you do next, right? You got to have some kind of actual physical location to have it sent to. And so, and many other things in the same way, right? Yeah. So for those of you who don't know, general delivery is when you just have something sent to a post office and they hold it there for you, and then you go in and show them your ID, and then you pick it up, right? And so, it leaves a lot of people stuck and desperate and hopeless. So let's see. In pathways, it's been revitalizing in the last couple of months. So things are going really great. It's beautiful. Love that program. Excited for it to continue to grow back to what it needs to be again. Connected with that program is it's another program called Care Connect, and it's specifically a program that rose up during COVID, and it's a program where people get assistance that have tested positive for COVID. And so it's trying to encourage folks to isolate if they can, to stay home and not spread COVID. And so in order to do that, people need assistance getting supplies, or maybe they need assistance for rent because they are unable to work during those times and may or may not have the financial support that they need. And so we get a list. It funnels to us through the county, and it's folks that have been determined to both be positive for COVID, but also to likely have a limited support system. And so then we become that support system. We make a phone call. Initially, we were like, what is that going to be like? yeah, so we heard you had COVID. So people have been extremely receptive, right? The people making phone calls are Care Connect folks, and so they're good at their work. They know what they're doing, so they call and they make contact, and they ask if they want assistance, if they need assistance or would like assistance, and many take us up on it, and we can bring them food and supplies, cleaning supplies, PPE. Cat food, dog food. One of the great questions on there, it's how many cats do you have, but how many pounds of dog do you have? And so the amount of dog food brought is based on not how many dogs, but the pounds of dog you have. So anyway, so they and then it's no contact. You leave it for somebody outside, and then again, there's some additional supports for rental assistance and stuff too. So in their last year, 2022, we had 108 clients in Care Connect, and I don't honestly know what that equals in number of groceries and rental assistance and all of that, utility assistance and stuff as well. And so I don't know how much longer that program is going to continue to operate. It's kind of needs based, and so we'll see how things go.
Yeah. And the landscape has changed since it was,
Yeah, absolutely. Absolutely. I mean, the reality is there's still a lot of folks that are going to test positive and need to isolate, and that need somebody to support them. A lot of the folks in these situations are folks that are on fixed incomes that are not very don't have a large network of friends or family anymore, and
support system.
Just support system isn't there. So let's see. Next, we'll talk about what are we talking about? Food box delivery program. So Gather Stock Box. So we used to operate a market style food bank. People came in, lined up, walked through, gathered the food that they wanted, put it in bags, hung out for a while, had a meal. It's beautiful. A lot of lovely stuff happened. But during COVID, we pivoted. You were a big part of that, Mitch, into a food box delivery program called Gather Stock Box. Go to gatherstockbox.com. Sign up for a food box, and you will have a food box delivered to your doorstep. We didn't necessarily anticipate that happened quickly after COVID lockdowns started to ensue and social distancing measures were taken. And so we weren't sure how long that program was going to operate like that. And now we don't know that we would ever go away from that kind of a format. One of the things we found is that we can contact a lot more people and deal with a lot more food insecurity throughout the whole county if we're bringing food to people, because a lot of individuals that are struggling to put food on the table also don't have the resources to put fuel in their tank to drive to town to get free food at a food bank, right? And so this is, it poses challenges. It's a larger scale project than what we had ever done with food as far as distribution of groceries and such before, but it's been amazing. We delivered in Thurston County 30,888 food boxes in 2022, and that would equal, I got the poundage on here someplace, 599,970 pounds of food, and that would just be the food that was weighed when we got it. So there was probably another honestly 250,000 pounds of food that wasn't weighed that was donated to us in addition to that. So we're looking upwards of 1 million pounds of food. Or 750,000 anyway.
My second oldest, Will, he
I heard about this.
He heard this in the service, and he was like, he's really good at Blender doing 3D art and stuff like that. And so he took those numbers, went home and asked me, how big is a box about that gets delivered, one box? And so he took that and he built a model of a person. Then he built a model of what it would look like to have 30,000 boxes or whatever it was there. And I mean, it just looks like a skyscraper next to a person. And he built that out so he could visualize it and understand, like, that's a ton of boxes. That's just a lot, you know? And it was like a cool little thing that he could do. But if you think about how much is moving through, and this is not all gathered. These are partnerships with food banks and with other things, and we have a crew of volunteers that take care of a lot of this stuff. So it's all like a community driven thing. Yeah. But just in one sense, it's amazing. In another sense, that it is needed to that degree is just a scary, tragic, crazy. I mean, it's hard to wrap your mind around.
Yeah, it really is. I mean, the stories that we hear about people's journeys, about people's lives, about why people need access to food. It's easy for people to be, I guess, dismissive of the need, but it's out there. There's a ton of food insecurity. And again, it's like for a lot of different reasons. Sometimes it's immobility. People having the ability to drive someplace to get their food needs met, right? Like there's a lot of, sometimes it's purely a financial need. There's a lot of folks that fall in a gap between they don't qualify for SNAP food stamps or whatever people want to refer to them as. So they don't qualify for food assistance, federal food assistance. They make too much money, but they actually don't make quite enough money to take care of all of their household. So I have to make choices. Am I going to put fuel in my tank and get to work so that I can get the money that we can get at? Or are we going to put food on the table? How do we balance this stuff out, right? So the reason people access Gather Stock Box and food delivery is just, it's broad, it's fast. There's a lot going on. There's a lot of reasons. And as far as volunteers go, I mean, there's a lot of volunteers that are delivery drivers I've not ever had the pleasure of meeting. There's a whole team of people from the East County, Lewis County, that I've never met. I've met some of them, but a lot, again, I've never set eyes on them. I would love to.
Some of those are connected
one of these days
to churches in East Lewis County that we get the boxes to them, and then they have their network that goes from there.
Yep. So Fridays are the day the East County boxes are delivered. We pack the boxes local in downtown Centralia, and we load those onto a box truck, and we drive them to Morton, and a local hotel there lets us use their parking lot. We offload those based on the numbers that are on the run sheets, and the drivers take them from there and they bring them to their community. And it's incredible. All the boxes that are delivered in the rest of the county, including like south and west of I-5, those are all delivered on Thursdays and packed mostly on Thursdays and delivered on Thursdays. And the volunteers pick all those up at the 408 location, the back alley, and pull up. And I mean, it's pretty amazing. Local pastors, local folks that are just volunteers doing whatever. They show up. Some just have, a 4-door sedan, and they're somehow cramming, 80, 100 boxes in their 4-door sedan. It's like Tetris out in the alley every day, right? It's like,
every week.
It's incredible, So I have, it's been just watching folks like Jonathan Biggers show up and volunteer and drive, Pastor Pete from Emmanuel, just it's beautiful to see the ecumenical outworking,
right,
and connection and whatever.
Well, that's why I try to point out to people that Gather doesn't own these things. Yeah. I mean, it's just you're just creating space to allow it to happen.
Yep. Want the need to get met, and it's crazy. It's beautiful. So let's see.
What do we got here? How many more do we have?
All right. We're just about there. The meals. We serve a lot of meals. 40,569 meals we served. Hot meals last year. I think that's like 111 point some odd meals every day. And so that's fabulous, wonderful. A lot of those are delivered in the community too. Apartment buildings around us that have folks living on fixed incomes rely on those meals. A lot of them go to folks that are stopping in and eating on site. There's other food related stuff that goes on. Had a couple of amazing programs sponsored by Save the Children this last year. We were able to provide food meal vouchers for folks that were receiving food boxes to go to their local grocery store and pick up all the supplies for Thanksgiving and for Christmas meals. And that was great for both local businesses as well as those that were receiving those food supplies. There's a lot of other stuff. We have senior food boxes also. It's just,
It's amazing work. It's amazing.
It is.
Like, I was just checking my phone because I literally got a text from your wife that said, if you're talking with Cole, please tell him to call me.
Yeah, my phone's blowing up.
So, I mean, this has been a marathon podcast episode. And we're not even done.
No.
There's still so much more. But I think what's important to touch on is, just how wide all the work is, how much more work there is to do.
Mm-hmm. Sorry.
It's okay.
It's a weird time for me to be the first time on that podcast.
You're all right.
You're good. Oh, did you show up on camera?
I don't know.
Maybe.
Maybe. If not, then you just need to.
I was going to say, one of these
Corner.
days, we just need to get me the microphone.
She's
That's
talking.
right.
I can't even see that one.
It's going to freak her out when I call her.
That's all right. Go ahead and just tell her we're almost done. If
Yeah,
it's
we're
an
back.
emergency,
So,
then
point is, just the scope of work is huge, and there's more to do, and there's more that can be done, and it's not just a gather thing; it's a community thing, and there's people that, like I said, it's just keeping a door open, and people show up and do the work, and how much of it is just counseling and navigating people through systems as well as like solving problems. How do we get food from here to East Louis County?
Yep. So I'll maybe close with this. Like, one of the things that I tell our volunteers, our staff, all the time, it's like, pay attention to that one person in front of you, right? Like, we talk about 30,000 meals or 750,000 pounds of food or whatever. And I mean, that stuff, it's significant. It matters, but it's all about like the one person that you're caring for at that given moment, the one person you're noticing, that you're looking in their eyes. Like, we are all one person, right? Like, I'm just one person. And like, it means a lot when somebody else just gives me a little bit of their time and attention. I feel like a human. I feel loved. I feel cared about. I feel significant, right? And so all of our programs really ultimately are about a whole bunch of ones, a whole bunch of just individuals that somebody's noticing, taking care of, loving, being there for, right?
Mm-hmm.
And it's just, if we can keep it focused on that all the time, it's not that
Which,
complicated.
I mean, that is the challenge. There's this work that is being done on this scale.
Mm-hmm.
So it is hard to, a constant reminder to stop and look at what you're doing, who you're helping. It's not just, going through these motions or I drive this box to here. There's a relational part to it. And that's why I think it's so effective for a church to be doing this. 'Cause I mean, like you said, all these people are made in the image of God. That's what drives this desire to seek people, find, recovery, to find help for their mental health issues, to find housing, to find food, to find, reconciliation, whatever it is. Such a critical part of underlying all of these programs.
Yeah.
It's people. It's people work.
Yep. That's it.
Oh, well, this is a marathon. I'm tired.
Whew.
My body's like freaking out.
Wife's calling.
I know. We're I'm gonna get in trouble again for you. So, anyways, thank you for doing this. I know we got so many more we can do. We can and so many topics to touch on, and I think I have some editing work ahead of me just to keep this concise and not drawing on too long. But
somebody can put it on the background, just work all day and just like listen to us rambling. I mean, sounds like fun to me.
Anyways, thank you for doing this. Thank you for all the work that Gather's doing. It's amazing, and all the people that you can't name that you want to name. You couldn't possibly rattle them all off the top of your head because you'll miss somebody. But I know you appreciate them so much, and I know that they know they're appreciated and they're cared for. But it's amazing. 2023 is another year to just continue to do more and keep trying to there's so much need and so much work out there. Yeah. So, hey, I love you.
Love you too.
Thank you for doing this with me. And I definitely have to have you back.
Let's get it scheduled.
All right. Thanks, man.
Yep. Bye.